Good morning, everyone. My name is Isabelle Dreyfus. I'm coming from Toulouse, in France. I'm very, very pleased to be with you today, even if the trip was a little difficult. And I'm very pleased to share with you my presentation dealing with the difficulties of communication we have sometimes to face in the management of our patients suffering from atopic dermatitis, and with the key we can find to try to solve this problem. Yes. The diagnosis of atopic dermatitis is quite easy and the prescription is consensual, but this is generally not enough. There are very few chronic illnesses with so many beliefs, therapeutic wanderings, use of alternative medicine, or grandma's recipes or do-it-yourself recipes. Both the last one are both a direct consequence of corticophobia. This suggests that there are original discrepancies between caregiver and patients that will interfere with communication, and it could even be said that what you say is or may be different from what your patient hears. It also highlights that very good quality of communication is a crucial question and a major element of the caregiver-patient relationships. So, why is it so difficult to communicate with our patients? First of all, in order to try to improve our communication with our patients, we have to be careful and to fight against some independent elements that will interfere with communication. Firstly, when your patient attends the consultation, it may be for him an emotionally charged moment, possibly in the critical period of his life with the disease, while for you it can be just another consultation, one more consultation, possibly in a busy day, and you may not be able to receive his emotional charge. So it's important to remind to take a time, a sufficient and precious time with each patient in order to fully adapt to all these needs, all these demands, whether expressed or not. In the same way, there can be natural discrepancies between caregiver and patients regarding their respective objectives or expectations. Caregivers are trained to solve problems with solutions that are based on techniques and science, while for the patient, their expectations are emotional ones. They really want to share their burden, their quality of life, their everyday life, and they want to have personalized answer to their everyday life and the burden. They want to have keys to improve their quality of life. So it's necessary to make a bridge between caregiver technique and patient affect. And discrepancies are also observed from the outset about regarding the cause of the disease. For the caregiver, atopic dermatitis is a chronic disease that evolves in flare-ups with an hereditary background, while for the patient, it's a curable disease because it has a cause, and most of the time, this cause is represented by a food allergy for the parents of patients suffering from atopic dermatitis. And concerning the desired treatment, patients who are reluctant to topical corticosteroids will preferentially turn to organic products or alternative medicine, while for the caregiver, the standard therapeutic will be the topical corticosteroid for the treatment of inflammatory lesions and emollients for xerazes. And when it doesn't work, in event of therapeutic failure, for the caregiver, it will be attributed to poor performance of skincare and a loud adherence to the therapy, to the topical corticosteroids, while for the patients, it's due to an ineffectiveness of the treatment because it's not adapted, because it doesn't treat the cause. As we view in the video previously showed by Françoise Elan, patients don't like and don't want topical corticosteroids. And in AD, corticophobia represents a major element of treatment failure. And adherence to topical corticosteroids is estimated around 32% in children, which that is lower than adherence to oral treatments in other chronic illnesses, around 50%. That's a very widespread fear. That's not only Franco-French. We can find it all over the world with many publications from different countries, like United States, Canada, France, Korea, Germany. And according to studies, corticophobia is estimated between 21 to 84% with a median of 56 percentage of patients. Little tired. And several hypotheses have been formulated on the origins of corticophobia. Erroneous beliefs and fear about addictions, about, for example, rebound effect. Also, misunderstanding concerning the side effects of the topical treatment that are often confounded with those observed with oral treatments. That can also be origin can also be from behavior with irrational fear or healthcare pathway that has been complicated with a lot of failure. It can also, due to vectors of transmission like medias, internet, but also surroundings, caregivers, and to this point, we have to be very careful to the language we use when we are talking about topical corticosteroids with our patients. So, how to manage and dismantle an erroneous belief? I have listed here some sentences that you have undoubtedly heard before with your patients. Eczema is caused by a food allergy. Topical corticosteroids are harmful for babies. They cause swelling. They have a negative effect on growth. A lot of things. And the first issue of the alliance with your patients is to fight against the breaks of communication and the erroneous beliefs. So what is a belief? It's a mental process experienced by a person who will adhere to an idea or thesis and will consider it as a truth. It can be sometimes, but not exclusively, specific and related to his experience, but it's also deep-seated need. It responds to a deep-seated need for various psychological reasons. So it will be necessary in the first step to detect the erroneous belief in the patient, and to allow this essential step, it is necessary to let the patient express himself about his experience, his anxiety, his fears, without judging him, and always with kindness, because it's very, very, very difficult to change an erroneous belief, and if we broke a patient in his belief, we lose him. Three models of patient-caregiver communication have been described. The two first of all, the paternalist model and the informative model, are the older and are most centered on the caregiver, and they are not popular for patients. They prefer the third one, the deliberative model, with a new one and patient-centered, and it corresponds to their choice because it responds to the need to choose together the best solution, the best treatment, the best option for them. So, when we have detected the patient's erroneous belief, we have to welcome it, to accept it, and to understand it, to better explain, to better guide our patient, to allow him to have another reading grid of his belief. And in a way, it's necessary to root, to replant, and to transmit the personalized and relevant information the patient needs according to the deliberative models he prefers, which will allow him to adhere to his treatment and also to to obtain his satisfaction regarding his skincare. Thank you for your attention.